Welcome to AMIX 2019. My name's Joel Dunning and I'm delighted to be here with Dino Plestis and we're going to talk about hints and tips for acute aortic dissection. Now Dr. Plestis, you've spent over 25 years doing aortic surgery. I hear you've done over 1,200 of them.
Yes.
and you have some fantastic sort of great hints and tips that I think would be really useful for people out there for aortic dissection. And I'd like to really start right from the very beginning, because I believe you've actually gone out there into your community to talk to emergency physicians to make the transfer safer. Tell us what you did about that.
Very good, Joel. Thank you very much for this wonderful interview. And I think it's a topic which is of great interest to me because these are very sick people and they require very fine management from the beginning to the time they come to the operating room and then in order to have the best outcomes. So from my perspective, I went out to all the emergency rooms in the area that I operate, and I truly sat down with the emergency room physicians and I educated them in terms of managing acute aortic emergencies. Because as you know, a very important thing is number one, to diagnose the disease, and sometimes it's easier said than done. But also most importantly, to manage the disease before and during the transfer to the center that will perform the operation for those patients.
So if you had a tip for anyone out there that does occasional dissections, would it be to get out there to your emergency department and tell them must have an arterial line,
Yes.
must have the better, or must get the blood pressure down?
Absolutely. You have to realize that the emergency room physicians see a lot of patients. So first and foremost, they have to be aware of the tips of the diagnosis of an acute aortic dissection. Why? Because acute aortic dissection behaves like an acute myocardial infarction. So quite often these patients will have an EKG and cardiac enzymes. This invariably will be normal, and then time can be lost in the process of finding out what's happening with those patients. So for example, if the description of the pain is a very important thing, and the emergency room physicians have to know about that. Acute onset, no previous symptoms, differential pressure between the two upper extremities, new murmur of aortic valve regurgitation. These are 4 tips that the emergency room physicians have to be aware when they see a patient with the possibility of an aortic dissection. And you have to know that some of these physicians, they see only 3 or 4 patients a year with that particular problem. Now, the fact that somebody has to go and talk to them personally and make sure that they understand those tips and they are aware of those tips and they can apply them, it's extremely important. And as I said, I personally went to a lot of emergency rooms and I created a little list with the diagnostic signs for those patients. And I found that very, very helpful, because those physicians can diagnose much easier and much more efficiently those patients. Now, as you know, managing aortic blood pressure is very critical for those patients. So just to put a patient in an ambulance and transfer the patient like 100 miles without any support, I think it's a mistake.
So you say it's unacceptable?
It's unacceptable.
Don't let people do that.
I don't think so. Why? Because so many things can happen during the transfer. And I think the number one important thing one has to determine is, number one, do you need to put this patient in a helicopter, to transfer the patient to a center that can perform this type of surgeries, or if it can be done by ambulance. And I think a direct conversation between the accepting physician and the referring physician has to be in order to determine what's going to happen to that patient. This cannot be left to a transfer center that can make their own decisions about that.
So who can go in an ambulance slowly and who needs that helicopter?
Quite often if the patient is hypotensive, if there is neurologic deficits, those patients it's better to be transferred as quickly as possible with a helicopter.
And I guess a pericardial effusion.
A pericardial effusion. And now if the patient does not have pericardial effusion, if it's hemodynamically stable, and the distance is relatively short, then one can put the patient in an ambulance and transfer the patient. However, I think it's mandatory that you control the blood pressure with beta blockers, N-cardine or any other medication before you put the patient in an ambulance, because this whole process will elevate the blood pressure of those patients. So during the transfer, if you have the ability to have a portable monitor with an arterial line in place and continuous monitoring of the blood pressure would be ideal. But even without that, I think, monitoring the blood pressure of the patient is very critical during the transfer of the patient.
And I think you said if you've got somebody stable with well-controlled blood pressure, if it was 1 in the morning, you'd actually wait till the next morning.
I think traditionally we say that we have to operate on these patients immediately, which it's something that has to be considered, obviously, for every patient with an aortic dissection. But I will tell you, in my experience, these are the patients who are the most difficult patients. They are operated quite often in the middle of the morning, like 2 or 3 o'clock in the morning, under the most unfavorable circumstances, and quite often with the least experienced person. So here you have the sickest of the sick, and you operate on them under the most unfavorable circumstances. So I always try to accommodate those patients in terms of bringing the best team available and the best surgeon available possible. So if there is a delay of an hour or two, when the patient is hemodynamically stable and the blood pressure is well controlled, it may be worthwhile. Now, that being said, any evidence of hemodynamic instability, any evidence of ischemia obviously will prompt an emergency operation for those patients. So I think one has to use a little bit of judgment when deciding to do the surgery on those patients.
It is a good message to get out that you don't have to rush everybody in. 4 hours is safe.
I think a couple of hours, I think it's relatively safe. I think if I may, you have to, in my opinion, you have to assemble the best team possible. Mm-hmm. Whenever it's possible to operate on those patients. Mm-hmm. Obviously, as I said, if you have the best circumstances, I think one has to strive for that, to get it. And when you have the blood pressure control, you may have a little bit of time, to do that, But by means, I don't want to get the message out that you have to wait for hours, for those patients. But let's say you take the patient to the ICU, you make sure you control the blood pressure. You send a lactate level to make sure that there is no evidence of ischemia in the gut or in the extremity. All these are factors, that I think it's important to know before you operate on the patient.
And who else shouldn't go straight to the operating room? So what would you do if you saw gut ischemia, leg ischemia, cerebral ischemia? What would you do in your center?
Gut ischemia, in my opinion, requires investigation prior to taking the patient to the operating room. And there is a lot of data, particularly from Michigan, to state that if you have gut ischemia, then it may be worthwhile to evaluate the patency of the SMA and the celiac axis prior to the operating room, and maybe take care of that problem before you operate on those patients, because that if somebody has a gut ischemia going to surgery, he or she is going to have gut ischemia coming out of surgery, and you may spend 6 or 8 hours in the operating room, and you may not benefit that patient. So I'm very careful in evaluating those patients. So any evidence of gut ischemia requires further evaluation of the circulation to the bowel. If there is frank ischemia, it may be worthwhile to cut this bowel out, and maybe buy some time, and then assess the patient in the hospital, in the ICU, on a daily basis, and make a decision regarding the appropriate management of that patient. Now, if somebody has somebody is in coma, then a serious consideration has to be given not to do anything about that patient, because we may not recover, those circumstances. But if there is peripheral ischemia, then this can be fixed in a variety of circumstances. So under those conditions, one has to take the patient to the operating room as soon as possible and take care of the problem.
Yep. So you're taking them to the operating room. What's your general technique? Do you do axillary cannulation first? Do you ever do femoral?
Yes. I think I think auxiliary cannulation is a very versatile way to put the patient on the heart-lung machine because it gives you the option of antegrade cerebral perfusion. So I always like to do that, if possible. Now, that being said, I always palpate all the pulses and I'll go where the strongest pulses, you know. So if, let's say, the subclavian is involved in the dissection, then I will go to the femoral artery and try to do the best under those circumstances. But I think my first choice will be right subclavian cannulation.
Mm-hmm. And then I guess going in as a general strategy, you know, you can do just quick interposition graft versus everything. You know, what's your general strategy?
I think my general strategy is to do the least possible. Mm-hmm. Dr. Crawford used to say that the number one priority is to get the patient out of the operating room alive. And as you know, the majority of the dissections are being done by surgeons who are not aortic surgeons. So I would not expect a non-aortic surgeon to do a very complex operation. So as long as you get the patient out of the operating room alive, and I'll be very specific about that. I mean, traditionally we like to resuspend the aortic valve, but if you cannot resuspend it, change the aortic valve. The patient has severe AI, you feel uncomfortable with that, just put a new valve in.
Yeah. And if you see a dilated root 4.5 centimeters, would you say?
I would just say, you know, try your best, you know, to get out of the mess instead of doing a complex aortic root replacement. Now, of course, if you are in a center of excellence with a surgeon who's very experienced in dealing with this type of problems, I would definitely recommend to do the complete operation. So I think that for the surgeon who is sitting in a hospital who's not an aortic center and faces a lethal situation in the middle of the night, I think the best way to deal with that is to put a tube graft in the ascending aorta and finish with that and get the patient alive, and let's deal with that subsequent complications of the aortic dissection later on, if they come.
And so, suturing these proximal anastomoses, I mean, they're delicate, thin bits of aorta. Do you have any good hints and tips?
Absolutely. So, the major thing with that is to create a good aortic wall so you can suture without tearing the aorta. So, I think my current recommendation is to put a piece of Teflon felt between the intima and the adventitia, and use bioglue to glue the piece of Teflon felt to the intima and the adventitia. So now, instead of media, you have a piece of Teflon, and that gives you enough good structure to suture. Putting also an external felt, it gives you extra security. So a piece of felt in between the two layers and an external felt, it gives you enough strength to suture. Now, I like to use 4-0 Prolene, simply because 4-0 Prolene makes small holes. Mm-hmm. If you use 3-0, the hole will be bigger. If you use 4-0, the hole is going to be smaller. And I would recommend to do the operation carefully, not to rush the operation. With the modern techniques of cardioplegia, we can arrest the heart for a couple of hours. So there is no reason to rush that operation, because most of the problems are because of bleeding, because of technical issues regarding bleeding. So I will make sure that the anastomosis is absolutely hemostatic. So let's say, for example, I completed the proximal anastomosis. I used the felt between the intima and the adventitia and outside. I use 4-0 Prolene suture. Then I will put a cardioplegia line inside the graft, and I will inject cardioplegia under pressure to make sure that there is no bleeding from this anastomotic side, because if you try to put sutures with the heart, with the aorta full, it's going to be very difficult to create more tears in the aorta.
You can never get around the back.
You can get around the back. So it's better to do it with the heart stopped. So now you have control over the situation 100%.
Yeah. And just getting that Teflon between the intima and the adventitia, if you've only got a partial tear, do you complete the tear? Do you tear it all the way around?
No. You just put it exactly where it's needed.
Where it's torn.
So invariably it's in the non-coronary sinus. So you have to cut the piece of Teflon to be equal in size with the non-coronary sinus. So you have to judge it a little bit. Usually a 2x2 is going to be enough, you know, to put it inside there, stuff it between the intima and the adventitia. Then you use bioglue, and then you take little clumps and you just put the clumps, and then that will take care of the problem. Invariably you create a leathery type of tissue in that area, which is very strong and can take the sutures very well and prevent the bleeding from that area. So I would leave it only in the area that's required.
And I think you were saying that Teflon actually causes better adhesion to the dacron graft because the aorta can't heal that.
Yeah, the dacron, the Teflon is extremely inflammatory, creates a lot of inflammation. So I think putting a Teflon felt will sort of fix this anastomosis to the best for the long term too, because you have to think about those patients in the long term. So when I was with Dr. Grip, we evaluated almost 3,000 anastomosis, and the incidence of disruption was very low, and I think to a significant degree was related to good suturing, but also to using the Teflon felt outside of the aorta.
So what about more difficult situations when you see the dissection flap going right over into the arch of the aorta, and how do you deal with those difficult dissection flaps?
It is. So if there is a secondary tear in the aortic arch or a primary tear, then you have to try to excise the aortic arch to the best to excise the tear to the best you can. So there are two possibilities. Number one, the possibility is in the tear is in the lesser curvature of the aorta. Then you can do you can excise it, you can bevel the aorta and excise it. And again, you put the Teflon felt between the intima and the adventitia, and you use bioglue, and you connect those two together, and then you put the Teflon felt from outside that secures the anastomosis. Now, if there is a tear between the brachiocephalic and the carotid artery, for example, where most of the tears are, then I think the best thing to do is to transect the brachiocephalic artery and utilizing the same principles. Because I think one has to excise the tear in the aortic arch. If you leave it there, then it's going to be a problem. Again, I think that this is not the most common situation. One has to be prepared for that. And that is why it's important to use antegrade cerebral perfusion for these situations. So if you have a right subclavian cannulation, then you can put gently a clamp in the brachiocephalic artery and give continuous antegrade cerebral perfusion. That will give you 60 minutes, So you have a lot of time, and I don't think people have to rush it. I think it's better to take your time to do the best you can, rather than to rush the operation.
What sort of temperature do you go to, Jimmy?
So there is a lot of controversy regarding that, but I will tell you, I do deep hypothermia. So I go down to 18 to 20 degrees, because number one, this is not an elective operation. Number two, you do not know what you're going to find. So you don't want to be stuck at 28 degrees, and then suddenly you have a tear in the aortic arch that you did not know about that. And now there is nothing you can do about that. Now you have to rush the operation. So if you are cooled down to 18 degrees or 20 degrees, then you buy enough safety, not only in terms of brain perfusion, but also in terms of liver dysfunction, in terms of bowel, etc. So you have to think about that. So when you are cold, you have plenty of time to do the operation. And although there is this tendency to say, oh my God, the patient is going to bleed, every aortic surgeon knows that the patients bleed not because of coagulopathy, but because of technical issues.
Yeah.
In the majority of the times, okay? I don't say that coagulopathy is not an issue, but in the majority of the time, there is a technical issue, and the majority of the time comes from the fact that deep hypothermia precipitates an anxiety. It precipitates an anxiety on me even today. So you want to get the operation done as soon as possible, and then you may cut a few corners. That is why I recommend to everybody to go down to 18 degrees, give enough time to the body to be cold. So when you arrest the circulation and you find a problem that you don't expect, you don't have to rush the operation.
What about intramural hematoma? No dissection flap. What do you do?
Intramural hematoma, that's a controversial issue. We had a wonderful lecture today by Haverick that he said an intramural hematoma is a type A or dissection, so it has to be treated as such. Nonetheless, again, if you are in a place that you don't deal with this type of surgery, it gives you a little bit more luxury to make an appropriate decision. But in my opinion, I think an intramural hematoma, particularly in a young individual, has to be treated as a type A or dissection. Now, if you have an 85-year-old person, maybe you leave it alone and do a CAT scan in 6 months or 3 months and see what's going to happen. But for the most part, younger individuals, I think they have to be operated on.
Mm-hmm. Absolutely. We've had it in our unit, you know, the odd person that comes and then suddenly they arrest just before the operation. Is there anything that can be done for this, or really have you just missed the boat?
I think the boat is gone, the bird is out of the cage. I think that, we have to realize that acute type aortic dissection is a lethal entity. And even in centers of excellence carries a very high mortality rate. So the minute the patient arrests, I think we have to talk to the family and let the person go. I don't think there's anything that can be done.
Yeah.
I mean, a heroic effort is to try to put a needle and decompress the pericardium, but for the most part, I think that is done. And I think sometimes we have to leave somebody to die with dignity, rather than to do a heroic effort under those circumstances.
And I guess just finally, I mean, how do you think aortic dissection management should be treated? Do you think centres should get together and get expert people on call all the time for dissections?
I think so. I think, as I said earlier on, it is one of the very complex entities in aortic surgery that quite often is treated under the most adverse circumstances. And quite often from the least experienced person. So my feeling is to improve that. Number one, we have to educate our physicians so they can diagnose the aortic dissection. There has to be a plan of management for immediate management of the aortic dissection in terms of the blood pressure control. Then the transportation to a centralized area where it can be managed will be ideal, if possible. And then have experienced aortic surgeons to do those cases. Because again, as I said, in the middle of the night, under adverse circumstances, dealing with this problem, it is very humbling, even for people who do aortic surgery for many years. So I think that is the way to, in my opinion, to improve to the best you can. Because as you know, aortic dissection, the mortality has not changed over the last 20 years. Everything has improved in the aortic surgery, but the management of aortic dissection, because many factors come to that.
And do you see a future where you could ever do a stent in the night rather than surgery? Do you think it'll ever happen?
I think it has been done, particularly in elderly individuals, but sporadic cases. We can hope for that, but I cannot see that in the immediate future.
One thing we'd like them to invent, isn't it?
I think it would be a very wonderful solution to a very complicated problem. But like everything else, all these complicated problems do not have easy solutions. So I think we will be operating for type A aortic dissections. The question is, how do we systematize and manage? It's like transplant. Not every hospital has to do the transplantation. I mean, we know that because of the perioperative complexity of management of those patients. So if there are centralized regions to be able to manage those patients, I think we may have an impact for that disease.
Great. Well, it's been an absolute pleasure talking to you.
It's a great pleasure.
Really
very good. I hope that I give some good tips to people who deal with that problem. And again, as I said, it's still a difficult problem. But I think that even if you operate in those patients and you feel that it's a complicated issue, I always recommend to be calm and take your time and don't rush the operation. I think rushing something creates many more problems rather than, and that's why give good cardioplegia to the patient. Make sure that you are in deep hypothermia, that you have cooled the patient at least for 35-40 minutes so that the core temperature is down. And don't look at the clock, but try to do a very good operation and prevent bleeding, because under those circumstances you will have the best chance to survive.
Brilliant. Well, that's a fantastic set of tips from an extremely experienced surgeon. Congratulations for all your hard work.
Thank you very much.
It's been a pleasure talking.
Thank you. It's a great pleasure.